Okay, so good afternoon. I'm Lisa, and I'm going to be talking about the Recovery RS trial. For this trial, we discussed, me and Hannah presented or prepared this presentation. So what was this study? So the Recovery RS study was an adaptive randomized control trial of non-invasive respiratory strategies in acute respiratory failure patients with COVID-19. So this came out of needing to know what to do with a massive amount of people with acute respiratory failure requiring oxygen support, but having to manage the practicalities of scarce resources in ITU, oxygen flow delivery problems, and making sure we got the rest of the patients. So the aim in hospital patients with COVID-19 requiring greater than 40% oxygen to achieve SATs of 94%, does the use of continuous positive airway pressure or CPAP or high flow nasal oxygen compared with conventional O2 therapy reduce the incidence of tracheal intubation or death within 30 days? So this was a combined endpoint so that was a primary endpoint. They did look at some other aims. So why is this even important? Why do we care? So we had issues with resources during initially the start of COVID when we didn't know the best strategy for managing these patients. We didn't know what to do for the best. We did know that once patients were intubated, they tended to spend quite a long time in critical care, and this massively impacted the resources we had. There were also news stories of oxygen failure or oxygen delivery failures, so we needed to know what was the best strategy to protect everybody. So there was a high admission rate to critical care during COVID-19, and obviously ventilated beds needed protecting for the sickest patients. There's previously been a lot of information and guidance about how we treat hypoxia in different situations, and now we know that actually COVID isn't the same as ARDS, but that was the thing we had to go on at that point. And we didn't really actually have a good evidence base for what to do. And obviously, we need to know what the better patient outcome is, preventing intubation and preventing death in our patients. So, does CPAP, high flow nasal oxygen, or oxygen therapy prevent the progression to intubation or death? So, methodology. So this was an open label, adaptive randomized control trial. There was no blinding because it's quite difficult to blind whether you're putting a CPAP on a patient or not. The sample size initially was calculated at needing 4,000 patients. So that gave provision to stop early if there was a significant signal towards benefit in early analysis. And they were planning to do 11 interim analyses on this. They decided that 3,000 patients were needed to achieve a power of 90%, but given dropouts and other factors, they were aiming for 4,000. The trial was only funded to run for 12 months, and at that 12-month point, case numbers were diminishing, so recruitment was getting very difficult. So with those two things in mind, recruitment ceased after 12 months. It was a web-based allocation, as we saw with previous recovery trials, and it was stratified by site, sex, and age. This study did not look at patients on intensive care, but rather on respiratory support units, so the work done before we got involved with the patients. And then in the centres when all three modalities were available, the allocation was one in each. If there was only CPAP or high flow, it was 1-to-1. There was a lot of crossover in this trial, so that was defined as changing to a different modality for greater than 6 hours, not just as a bridge to intubation. And any escalation to intubation was at the discretion of the treating teams, so there was no real firm point to when this happened, and it was an intention to treat analysis. So the inclusion criteria. So patients had to be confirmed or have suspected COVID-19. They had to be greater than 18 years old, and they had to need greater than 40% oxygen and have stats less than 94%. And these patients had to be suitable for intubation. There were no limitations in therapy for these patients, otherwise very different choices may be made. So exclusion, those needing intubation or ventilation less than an hour after admission were obviously very sick and needed intubation earlier, so therefore weren't counted. Any pregnant patients and anybody with a contraindication to any of the arms. So obviously, if you can't give them what they're allocated to, that's quite tricky. Unfortunately, there were only 1,277 patients were randomised, and then 5 were randomised twice. 8 withdrew and 5 patients lost to follow-up. So we can see that actually we've not got a massive study size here, and it was well below what we were going to get the power right. However, in all characteristics, they were well matched at baseline. So what was the intervention? They're either given CPAP or high flow nasal oxygen. In the CPAP group, the mean PEEP was 9.5 centimetres of water, and this was received by 91.6% of those allocated, but there was about a 15.3% crossover. For the high flow nasal oxygen arm, the mean flow was 50.8 litres per minute, and again that was received by about 92%, with a quite large crossover. And obviously there were breaks from treatment permitted for comfort, because you can't have CPAP on your face for that long without developing issues. In the control arm, this was conventional oxygen therapy. So there are a number of devices ranging from nasal cannulae to non-rebreathe oxygen masks. And that allocation was received by 98.3. Obviously, it's a lot easier to give that level of oxygen therapy as opposed to CPAP or high flow nasal oxygen. And there was a bit of a crossover there in 23% of patients. So the results, what did we actually look at? So there was a primary endpoint. So it was a combined endpoint of tracheal intubation or death within 30 days. And we had a number of secondary endpoints. So ICU admission, the time to intubation, duration of mechanical ventilation, critical care length or hospital length of stay. And there was also a safety element to this, because there can be a lot more safety implications using CPAP in certain areas. So what did we actually find? So there were 2 sets to this. So initially, CPAP versus conventional oxygen therapy. So that primary endpoint of mortality and intubation. So they found that this was significantly reduced in the CPAP group, and most of the difference was in intubation rate. So although there was a change in mortality at 30 days, the requirement for patients to go on to intubation was less, significantly less. And then we looked at the secondary endpoints. So the requirement to escalate to intensive care was less with CPAP. There was a longer duration in time to intubation. However, if they were intubated, there was no significant difference in duration of mechanical ventilation or critical care length of stay, of hospital length of stay. So they tended to stay there for the same amount of time, just potentially with less mechanical ventilation. And however, there was a significant increase in adverse events, these being pneumothorax, pneumomediastinum, hemodynamic compromise in the CPAP group, which, knowing some of the physics regarding CPAP, is understandable. In the high-flow nasal oxygen arm, there was no significant difference between high-flow nasal oxygen in intubation, death, and there was no significant difference in admissions, intubations, or length of stay. So what can we say about this? So CPAP reduced the need for intubation or death in hypoxic patients with COVID-19 in comparison with high-flow nasal oxygen or conventional oxygen therapy, which is something that's quite useful and nice to know. You may have heard a lot of people going, well, why haven't we intubated this person sooner? Well, actually, we know that CPAP can help for longer, and it is the right thing to be doing. So looking at the study itself, there were quite a few strengths. Obviously, this is a randomised control trial with concealed allocation. It was an intention to treat analysis, which is always the better option. And there was a near complete follow-up with only a small amount of dropout. It needed to be this way given the situation. It had to be at the right time. We needed to be able to study this and work out what the benefits were quickly before we got overwhelmed. And it was a multi-centre trial, so given that people were escalated at the discretion of the clinician, there was no real bias between which clinician chose what to do. However, this was an unblinded trial. Like I said before, having or showing, being able to blind somebody as to whether you'll be put on CPAP or high-flow nasal oxygen is a bit tricky. And it wasn't the sample size that was planned for, and it was not very big. There was quite a bit of crossover in the results, so it means that we can't generalise these results particularly well. And we had no defined criteria for intubation, so it very much depended on which clinician was there at the time, which may cause or lead to some issues with the results. So how will it change our practice? So as we found out, CPAP is preferable to high-flow nasal oxygen and conventional oxygen to prevent or delay intubation, which I think we probably now know from seeing our patients. However, this being so early was quite useful to confirm, and this might be useful to help prevent overwhelming the ITU resources. So has anyone got any questions?
Lisa, in the previous slide, it's mentioned that the CPAP is superior to high flow, but this study actually compared CPAP and high flow versus conventional oxygen therapy.
It was a 1:1:1 ratio, so...
Okay, so it's also compared CPAP with high flow?
Yeah.
Okay, thank you.
And thank you to Hannah for organising this presentation for me.
Okay. Thank you, Lisa. Thank you.
Thanks.
Thank you, Lisa.